So it's really great to be here at this joint event talking about whether to intersect. Before we start, I want to say, firstly, thank you for joining us. It's really fantastic to see such an incredible turnout today. I also want to let you know that we are recording the session. So if you don't want to be recorded, feel free to keep your camera off. And please contact the event organisers if there are questions that you want to be edited out of the recording. It would also be great if everyone could keep their microphones off, except for when presenting or asking a question. So now that the housekeeping is done, the topic we're going to be discussing today is one that I grappled with during my PhD, about how mental health relates to the social and economic context of people's lives and what that means for how we think about mental health interventions. We're going to be drawing on mostly qualitative evidence from mental health programs that I and the other speakers have been involved in low resource settings on multiple continents, to draw out some of the similarities in why people don't seek care for common mental disorders or why they disengage from services, and what lessons we can take away from this. I should point out that these programs were primarily dealing with common mental disorders, that is, experiences that could be classified as depression or anxiety, which have been a big focus of global mental health initiatives over the past 15 years or so, and are by far the most prevalent mental health conditions. In the discussion, it'd be great, we can come back and talk about how our observations might have differed if we'd been focusing on the less common but more severe end of the mental health spectrum. So here's the plan for today. We have 4 brief talks covering research from India, Mexico and Uganda. Alex and Rochelle will then offer their reflections and suggestions for how we can move forward. And at the end, it'll be great to hear from you with questions, comments and ideas about where we go from here. So I apologise to those who have read anything about global mental health who will no doubt be bored to death of hearing about the treatment gap. But this is a brief recap for those who are less familiar with the field. Grace Ryan from the London School of Hygiene and Tropical Medicine gave an excellent lecture last month in which she argued that in order to gain traction for mental health within the global health agenda, a clear and simple message was needed. And that message was that 1, mental health problems affect a vast number of people, and 2, that most of those people don't receive any treatment. This is what we mean by the treatment gap, the difference between the number of people who meet diagnostic criteria for a disorder and the number who receive treatment. And of course, framing the problem in those terms leads to an obvious conclusion in terms of what we should do about it, i.e., we need far more mental health services to fill this gap. It's implied in this argument that those who have a disorder must need treatment, and that mental health services are the solution to the widespread suffering that is captured in prevalence surveys, which mostly reflect common mental disorders. This simple argument is given as the core rationale for many major international programs, WHO reports, academic publications and guidelines that have been highly influential in terms of how academics, governments and international agencies think about their mental health activities, just a few of which I featured here. And until very recently, closing the treatment gap was the sole mission of the Centre for Global Mental Health, which is the quote on the bottom right. So one understandable response to this event was summed up by Dr. Sumitra Pithare, Director of the Centre for Mental Health Law and Policy in India, who suggests that surely we've moved on from this already. Back in the old days when mental health wasn't yet on the global health agenda, we coalesced around this simple argument in order to gain some traction. But haven't we now all accepted that mental health services aren't going to solve everything and that we need social and political solutions? And indeed, there have been some high-profile moves away from the singular scaling up story towards a more multifaceted agenda, for example, in the 2018 Lancet Commission on Global Mental Health. But I don't think the treatment gap dies that easily. If we look at the Wellcome Trust's brand new strategy that was announced just 3 weeks ago, mental health is one of their top 3 priorities. And when they sum up the central problem in mental health, what is it? It's the treatment gap for common mental disorders. This framing of the problem continues to shape the way that we think about solutions. Despite its hard to shake influence on the way we think about addressing mental health around the world, the question of why the treatment gap exists hasn't received as much empirical attention as we might expect. In the World Mental Health Surveys, the treatment gap was measured by first administering standardized instruments or questionnaires, and then asking those who score above an agreed cutoff point, that is, those who meet criteria for a mental illness, whether they sought treatment for their mental health or emotional problems. The statistics generated by these surveys, which had over 100,000 participants across 24 countries, are cited over and over again, usually to justify the need to scale up mental health services. But a key finding that is much more rarely cited is that they asked the people with a disorder who said that they hadn't sought treatment, why not? By far the most frequent reason given is that people said they didn't need it, followed by people preferring to deal with it by themselves. In other words, data from by far the biggest study to investigate these questions to date suggests that the treatment gap doesn't so much illustrate the lack of supply of mental health services, but rather the lack of demand. We need to pay far more attention to why people don't use mental health services, even when they're available, if we're going to provide support that makes sense to people and that meets the needs of those the field exists to help. So my PhD project tried to explore this question in a rural district of Madhya Pradesh in central India as part of the PRIME program. In PRIME, treatment for depression was made available in local health facilities, but despite increased availability and accessibility of services, there was no reduction in the treatment gap for depression, which is again consistent with the idea that the key barrier is demand rather than supply. Typically, when we talk about lack of demand for mental health care, we talk about stigma or low mental health literacy. But when we're talking about common mental disorders such as depression, I think these explanations ignore the biggest reason. These quotes are from a qualitative study I conducted with colleagues from Sangath, and I think they highlight a few important observations. Firstly, the people we interviewed definitely agreed that they were suffering. This is important to emphasize because what we're not trying to do in this talk is to minimize the pain experienced by people who receive a diagnosis of mental disorder. They were clear that their suffering was real and that things were not all fine in their lives. But importantly, they did not generally conceptualize their suffering in terms of an illness or a health condition. The people we spoke to, all of whom screened positive for depression, saw their feelings as an issue of stress or tension, and they clearly linked these experiences with their social and economic situation, primarily poverty, but also issues relating to gender inequities, relationship problems, and issues linked with poverty such as debt, premature deaths of family members, domestic abuse, men becoming addicted to alcohol, leaving their wives to provide for their children alone, poor working conditions, lack of affordable and quality education for their children, and to affordable and effective healthcare for the many general health problems that people experienced. Most people we interviewed worked 7 days a week in manual labor jobs in over 40-degree heat during the summer for very little money. So their lives were hard. And in the face of this ongoing hardship, they simply didn't believe that a health worker would be able to make their stress and their suffering go away unless they could actually help to change their circumstances. I think it's disingenuous to reduce this reason for rejecting medical help for social problems as stigma or lack of awareness. When we asked people what kind of help they thought they needed, they talked about government schemes to help people out of poverty or of needing solutions to abusive family relationships, not help to think differently about their situation through talking treatment or medication to stop them from worrying about it. They were asking for a fundamentally different sort of help to the support that was being offered, help that engages with the reality of their lives within a specific social and economic context, rather than locating a problem within the individual. When demand for mental health care is discussed in global mental health, much of the discourse assumes that people are simply wrong in assessing their own needs. Awareness campaigns are commonly offered as the solution to educate people that their needs do fit our services, rather than listening to people and adapting interventions to meet their needs. Danielle Nettle studies health inequalities in the UK, such as people with fewer resources getting pregnant younger or having less healthy diets than their wealthier peers, which are also often attributed to a lack of knowledge. If only the working classes were educated to realise that the correct choices are those made by the middle classes, they would no longer act against their interests, so the logic goes. But Nettle argues that there are perfectly rational reasons why these choices make sense if we understand the context within which people are making them, which might be very different to the considerations facing people in more affluent environments. In other words, we can learn something about what people want, need, and value from their behavior if we view people's actions as those of rational agents. I think we should apply the same starting point to why people living in poverty often reject mental health services as a solution to their suffering. I'm sure everyone on this call is very aware of the evidence on social determinants of mental health and knows that the problems that people attributed their depression to do in fact cause mental health problems. They're not mistaken in drawing these links. And there is now increasing evidence to suggest that people living in relative poverty are less likely to benefit from mental health interventions, both psychological and pharmacological, than those who are more affluent, which makes a lot of sense when we consider what we know about social determinants. Treating people and then sending them back to the same conditions that are making them ill is like shoveling snow while it's still snowing. It's also important to remember there's very little evidence that scaling up mental health services makes any difference to the prevalence of mental disorders. The treatment gap argument is sometimes taken to imply that if services were more widely available, mental health conditions would be less prevalent. But there are huge differences in the availability of mental health services between countries that aren't associated with the prevalence of common mental disorder. Anthony Jorm and colleagues used data from 4 high-income countries that substantially increased access to mental health services between 1990 and 2015 and found no corresponding decrease in prevalence. On the other hand, policy changes that address the social determinants of health can have a demonstrable impact on the prevalence of common mental disorders. And there are 3 examples of this on the right, in which increasing minimum wage, reforming immigration policy, and providing national financial assistance schemes to families were shown to have an important effect on the prevalence of mental health problems and on suicide rates. So if we actually want to improve population-level mental health, then scaling up services to close the treatment gap doesn't appear to be the most effective way of achieving this. So what does this mean for global mental health? Well, first, I think the time has come to move on from the treatment gap as the central metaphor in global mental health, as Sumitra Pathare argues, and recognize that mental health is social and political, not just a technical problem of getting treatment to everybody who meets diagnostic criteria. Framing the way in this problem risks limiting our imagination in terms of solutions and wasting scarce resources on delivering interventions that a large proportion of those they're targeted at simply do not want and are unlikely to achieve their aims. Now that mental health is firmly on the agenda of both international organizations and national governments, we no longer need this simplified narrative. We need to start advocating for quality over quantity, to properly serve those people who are seeking help, rather than seeking out more people to receive services that can't meet their needs. So I think one of the tasks for global mental health practitioners, researchers, and advocates going forward is to reform services before thinking about scale up, creating services that are high quality, that protect people's rights and dignity, and that think outside the box in terms of what mental health care looks like to take into account the full range of people's needs and engage with their social realities. But I also think there has been a vast imbalance in global mental health thus far between treatment and prevention, and between individual interventions and upstream strategies to improve population mental health. The field has been preoccupied with individual level treatment over public health measures, partly because they're easier to evaluate, but partly also because the discipline has been driven disproportionately by psychiatrists. But as the Lancet Commission in 2018 acknowledged, individual interventions will never achieve population impact, so this cannot be our sole focus. Improving living standards is necessary to truly address common mental disorders, and that involves getting political. Income inequality is not inevitable, it's a political choice. Racial inequality and gender inequality are not inevitable. They too are political choices. Research in global mental health can focus on identifying the best leverage points to improve population mental health, using evidence to lobby for action on these, and evaluating the impact of policy choices to inform better decision making. Practitioners and advocates need to be vocal in pointing to the social conditions and the political choices that influence mental health, and organizing, along with communities and people with lived experience, to advocate for action on these. None of this is easy, but then neither is scaling up mental health services. So in conclusion, I'm arguing for recognition of 2 different strands to global mental health. One that focuses on service reform and a second that focuses on public mental health and addressing social determinants across diverse settings. And this is why we were so keen to organise a joint event between the Centres for Global Mental Health and Society and Mental Health. Services are obviously important, and improving them is an important issue for global mental health to address. But it's also essential that we don't just pay lip service to the social determinants when talking about etiology, but that we also use our understanding of the links between social context and mental health to create social solutions and advocate for more mentally healthy societies. We need to conduct research across contexts other than the UK to generate evidence that is relevant to different settings, because we know that generalizing from Europe to everywhere else in the world doesn't work, and generate international solidarity for related activism on cross-cutting issues. And I believe we need much more prominence for this type of work as part of the global mental health agenda. This is where I see the work of these two centres potentially intersecting in future. I'm going to stop there because I apologise, I know I'm over time, but I look forward to discussing further and hearing your thoughts. I'm going to hand over to Georgina Migueles-Fonda.
Thanks so much, Tessa, for that really wonderful presentation. And everyone, just please bear with me for a sec because I'm not having a technology day. Right. I think that should be about fine. So yeah, hello, everyone. Thank you so much for being here today. It's very exciting to see so many people and so many familiar names. I'm very happy to be sharing some of the reflections from my PhD work with you all. I completed my PhD at the Centre for Global Mental Health and LSHTM, and now I'm based at King's, and I'm still a member of the Centre and also a member of the Centre for Society and Mental Health. Again, very happy to be here. So for my PhD, I had the pleasure to collaborate with Compañeros en Salud, or Partners in Health in Mexico. And the data that I will present today was collected as part of an evaluation of their mental health program, which they are delivering in the Sierra Madre of Chiapas, which is this really beautiful place that you can see in the screen here. CES started the mental health program about 2 years after they started delivering primary care services in 10 rural clinics in very small communities of Chiapas. And the work they did and still do is really incredible. They provide mental health services in a place where there had never been any services available. And I remember I was instantly fascinated by their program because they provide constant training and supervision to medical doctors to make sure that they can deliver mental health services. They ensure that there is a medication supply. They support people with referrals to specialist services. And they are doing something that I was taught in the MSc for Global Mental Health that was one of the key solutions to tackle the lack of access to mental health services, which was to deliver mental health services integrated in primary care clinics, which are of course close to where people live and work. Yet most people who ever attended services never came back for a follow-up consultation. And this is why I decided to start this presentation with this question in the title. Why are people with mental health problems not engaged in primary care services? Sorry, and this was a question that I was trying to answer for a lot of my PhD, and which has driven many heated discussions with many people. So it's a question I will try to at least partially answer here. Right, so what proportion of service users attended follow-up consultations? So when evaluating the program, I looked at data from people with depression and anxiety only, and please keep this in mind. You can see here the number of service users that attended 1, 2, 3, and up to 13 consultations. So the orange bar shows how many people were scheduled a consultation, and the purple bar shows how many actually attended. And you can see that at the second session, the numbers significantly drop. And this is a trend that is commonly observed in many healthcare settings around the world. And I'm just hoping the study that I conducted can provide some insights of some of the causes for this. So right, to make sense of the findings, there's a few things that need to be said about the context. And so this program was being implemented in the state of Chiapas, where about half of the population lives in rural communities, a third live in poverty, and in most of the communities where CES delivers services, live in extreme poverty, and the communities are these little blue dots over here. And in Mexico, people who live, the definition for people who live in extreme poverty is that they lack the resources to satisfy their basic needs. So all the things are that this is a very mountainous region. Access is very difficult. To access many of the communities, it is still necessary to travel through dirt roads that are severely damaged every rainy season. There's no phone signal. There's very limited access to internet. And where are the specialist mental health services in the state? Of course, they are in the capital city, which is about 7 hours away from the communities, sometimes more. So when CES started this mental health program, the expectation was that it would facilitate access to mental health services. And it has, but perhaps not to the degree that it was desired. And I suggest, based on this work, that there were 2 barriers to engagement. And the first of these barriers relates to resources. And I know, especially if you are part of the global mental health field, you probably heard this a million times, but I generally think that it is not enough, because it is a reality in many settings, particularly in poor settings, that mental health services are not available and are not accessible. In the place where this program is being implemented, before CES arrived, there were no medical doctors, there were no medicines in the clinics, only the buildings were there, but they were empty. So CES has guaranteed that, I'm sorry, when I say CES, this is Compañeros en Salud, which is the organization I'm talking about. I should clarify that ages ago, sorry about that. So CES has guaranteed that there are medical doctors staffing these clinics each year, but the reality in the rest of the state and in the majority of the rural settings in Mexico is that there are rural clinics have no doctors, have no nurses, have no medications, and they can't provide any health services, let alone mental health services. So that is an important thing to mention. Even in these clinics where CES works, resources are often insufficient. One medical doctor needs to see many patients a day. For mental health service users, that often means that they can't access counseling, and so medical doctors end up only being able to assess symptoms and prescribe medication. Another important barrier are long waiting times, and this is really important because it has very huge implications. So for people to attend health services, that means that they often need to miss a day of work, or at least have a day of work, which is not seen as an option, I think, anywhere in the world, but particularly in places where there are high levels of poverty. And finally, there are not enough specialists, and this is also crucial because we know that for services that are delivered by non-specialists to be of quality, it is essential to ensure that there is supervision available. So I wanted to show you here a quote from a service user. These sort of comments were very common among the participants. And this service user is talking about how she feels about now there being services available at the clinic in her community, which used not to be the case before CES started working here. And she says, honestly, I would like the clinic to grow, that more of us would get better. Here in the Sierra, a person needs medicine. There are no resources, and she means either money or transport to go with private doctors. She points out to an issue that is very common still in many parts of the state and of the country, that is that to receive mental health services, people often have to rely on private services, which of course come at a cost. And the second barrier is the extent to which treatment is adequate to people's needs. So most people who ended up receiving treatment for depression and anxiety presented to the clinics with some form of physical, social, or financial complaint. And here you can see an example. This is a quote from one of the service users, and this woman explains why she started going to the clinic. And she says that she started going because she felt cold inside, her heart hurt a lot, again, these physical complaints. And she says, my husband got ill and my child got burned. I think I started keeping all of that. I waited like 2-3 years before going to the clinic. I endured it. I had worries because my husband was ill. Many of my kids were at school and I would run out of corn, out of soap, out of sugar. I had to wash other people's clothes to support my children. And that's why it all started. The doctor said that it was that illness, and she was referring to depression. The second thing is that we observed that people attend services when they perceive they need services, and no surprises there. Tessa mentioned that this is widely reported in the literature. But as I mentioned before, most people were only receiving from only able to receive pharmacological treatment, and this was about 70%. And so when given a solution that addressed the symptoms but not the causes of the symptoms, it's not surprising that many people reported that the medication was not helpful. And this was a very common thing that people said. So the quantitative data demonstrate that many people disengage with services. Also, when conducting interviews, many people reported not taking medication because they didn't find it helpful, or because they spoke about getting bored of taking it for a very long time, or reported mostly getting side effects from the medication and no actual benefits. At the homes of participants, it was very common to find unused bottles of fluoxetine, and many people were prescribed it, but few actually took it on an ongoing basis. Physicians also reported a pattern of people coming and seeking services, being prescribed treatment and then not returning to the clinic. And here I put a quote from one of the medical doctors, and she says that that people, they come, they let out everything they have been carrying since who knows when, they feel better, and then they don't come back. I've seen it with some patients, it's a cycle of maybe 2-3 months, and then they come back because the cycle starts again. So clearly there's an issue in terms of how adequate the treatments are for the population. But this is not to say that the program didn't benefit a few people. For those that were primarily concerned with controlling certain symptoms, medication was really helpful and it really changed people's lives. So this photo was taken by a participant who used to have anxiety attacks, and CAs helped her attend a referral to a psychiatrist and enable her to access free medication each month. And this has improved her life significantly. So there are many examples of that. So what should we take from all of this? I think first of all, that people have a right to health, to receive mental health care that they need. And this should be designed according to needs and adapted to particular contexts in line of whatever people understand is well-being, or in line of what people see what brings well-being to their lives. And crucially, treatments and services should be accessible and should be of good quality. But people also have the right to live healthy and happy lives. And this is not a surprise, and I think everyone would agree with that. But I think that will not only be achieved through health services, particularly in contexts with high levels of poverty, of violence, where there are many other social problems. Until we meaningfully address the causes of distress, making services available will not mean that these services will be used or that they would actually bring a benefit to the majority of people who have depression and anxiety. Thank you all for listening, and thank you to the people who helped me make this research. Oops. Sorry. Oh, sorry. Crucially, I have to say, I will hand over to Constanza Torre, who will be presenting an example from Uganda. Thank you, everyone.
All right. Thanks so much, Georgina and Tessa, for amazing presentation. So I'm going to try and share my screen. Could you just let me know whether it's working? Okay, great. All right. So good afternoon, everyone. Thank you so much for inviting me to participate in such a great discussion. It's really exciting to have the chance to discuss some of my findings from my recent fieldwork with such a great panel and audience. My name is Costanza Torre, and I'm a third-year PhD candidate at the London School of Economics. My presentation today is entitled Throwing Therapy at the Problem, Mental Health Interventions and the Humanitarian Accountability in a Refugee Settlement in Uganda. And I will present some findings that stem from my recent ethnographic fieldwork about socioeconomic determinants of mental health and psychological interventions aimed at refugees. So just a little bit about my study and where I conducted it. Between January 2019 and April 2020, I conducted ethnographic fieldwork in Palabek refugee settlement, where I have been researching mental health and psychosocial support interventions, and especially refugees' understanding of their programs and their role within the wider humanitarian system. I spent the vast majority of my time living in the settlement with a family of South Sudanese refugees, and during my work, I've followed several NGOs and cases of mental illness for extended periods of times, conducted interviews with a variety of actors, and analyzed the mental health clinic records in Palabek. So Palabek is a really interesting and complex context that deserves to be understood a bit better if this talk is going to make sense. So it's a recently established settlement. It was established in 2017, and now it's home to more than 54,000 refugees. And under Uganda's often very highly praised refugee policy, every refugee that comes to the country is allocated a plot of land to cultivate to allegedly achieve self-reliance and independence from humanitarian assistance. And while this is great on paper, of course, as it often happens, the reality is much bleaker. And this largely depends on the fact that Uganda is one of the world's most underfunded refugee situations, and one in which basic needs are not, and in truth have never been, adequately met, and especially food ones. The food is not enough is one of the most frequently heard statements around the settlement. And we could talk more at length, of course, about how what that statement means beyond its literal meaning, of course. Furthermore, in life in the settlement is, in Palabek specifically, is not easy because the plot of land are often too small and the quality of land too poor to allow for anything beyond cultivation of small amounts of vegetables that allow at most for dietary changes and certainly not for any meaningful economic stability. Lamo district, where the settlement is located, is one of the least developed areas in Uganda, which still suffers heavy social and economic consequence of a recent civil war. And it's an area with an economy that's slow and practically moribund, and where establishing a livelihood is practically impossible. The evident state of chronic poverty that Palabek suffers was well described by the words of an astonished UN worker that visited the settlement earlier this year, and that said to me that Palabek was by far the worst settlement in Uganda in terms of livelihoods. Now, unsurprisingly, perhaps, considering the picture that all of this paints, and as Tessa pointed out importantly earlier on, the mental health needs of refugees in Uganda have been described as dire, and they are definitely real. High rates of common mental disorders like depression and anxiety have been pointed out, and an alarming increase in suicides in settlements across the country was highlighted earlier this year and made international news. Like in many humanitarian contexts worldwide, mental health and psychosocial support interventions are now a steady part of the humanitarian response to the refugee emergency in Uganda. And in many other settings, many other similar settings, they consist in psychoeducation sessions and short psychological interventions like cognitive behavioral therapy, for example. Uganda is, however, a little bit different and very interesting in this sense, because since 2018, it is the site of a UNHCR coordinated pilot, which has introduced the prescription of psychiatric medication in the small health centers in Palabek that now include a mental health ward, and where where mental health staff usually prescribe psychiatric treatment to patients that, as Georgina also mentioned earlier on, often come with social or physical complaints. And in this, it's worth pointing out that the influence of a global mental health thinking of policy is evident. On the one hand, like Tessa pointed out earlier on, the field has indeed been dominated by psychiatrists until very recently. And in the words of Kiermaier and Pedersen, it has risked becoming applied neuroscience. Also, this is coherent with one of the main pillars of global mental health, of course. Sorry again to anyone who knows enough about this to, I'm sure, almost guess what I'm going to say. That is the integration of mental health in primary healthcare services. And this follows quite neatly the logic of the treatment gap that we're discussing today. That is an effort to bridging the gap by making psychological and psychiatric services more easily accessible to possible beneficiaries. So the point that I wish to make here is that understanding suffering in Palabek through psychological suffering in Palabek and addressing it with a treatment gap frame is in essence means to understand severe psychological suffering as a psychological issue with psychological causes that calls for the mobilization of psychological solutions. And this is in spite of the fact that people during psychoeducation sessions and in general in various interactions with mental health and other workers are extremely clear and vocal in identifying the causes of common mental disorders that are so prominent across the settlement in the socioeconomic hardship they experience. In Acholi, the most widely spoken dialect in Palabek, there is no direct translation for English terms such as depression or anxiety. And the translation in the local dialect can be rendered in English with the expression to overthink, to be with many thoughts. But overthinking, several people explained to me, is very different than an illness. So there's no reason to address it through with a medical solution. One South Sudanese woman said that poverty causes overthinking, or when your child is sick and the money for the medication is not there. A refugee elder explained that people overthink when they lose their property, like refugees here. Here in the settlement, you will find that everyone is overthinking. They're thinking the land we are on now is not good for cultivation. And if you don't have food in the house, you will think of what you had before because they, UNHCR and various NGOs, are not giving enough food. That is different than an illness. A South Sudanese man that was diagnosed with depression expressed his desire to commit suicide by saying, by then, or before the war, I was the man in the house. I could cultivate and provide for my family. But these days, I'm useless and I'm thinking of ending my life. And while in Palabek, the relationship between lack of food and basic needs and mental illness, and the way that the lack of basic needs contributes to deep individual and social suffering is really particularly evident. And this, of course, makes intuitive sense. The lack of food resources implies a lack of economic assets that refugees can build on to effectively achieve or hope to achieve self-reliance for and plan for a future for themselves and their families and their communities. The resulting and perhaps inevitable psychological distress is often manifested through somatic symptoms that is, again, often diagnosed as depression by psychiatric staff. In response to this, patients are frequently prescribed antidepressants. During my research, though, I've analyzed the mental health records of Palabek mental health clinics. And it's quite interesting, actually, because what these analyses reveals is that there was a sharp increase in diagnosis of depression between early December and late March for at least 2 consecutive years. And this is not just any time of the year. This is the peak of dry season in Uganda, during which food is its scarcest because the humanitarian assistance, which is already very inadequate, cannot be complemented by cultivation of vegetables. And mental health staff are deeply aware of this and will explain this in a very matter-of-fact way, as you can see in the quote that I reported on that I put on the screen, that is from an interview with a psychiatric nurse that said, there is a big seasonal difference between mental illness in refugees and in Ugandan national, who it should be remembered, live side by side. For the nationals, in dry season, they are less stressed. They associate with others more often. While in rainy season, there is a lot of work to do, and then you see depression rising. But for the refugees, it is the opposite. Here during dry season, you will see many people with stress disorder and major depression. It is strongly food related. The food given is little, and you have to sell some of it to buy things like salt. Whereas in rainy season, people can plant some things and at least change diet. And what I think that this quite clearly shows is that here the distress is understood by mental health staff as the manifestation or the emergence of a psychiatric condition, and it's medicalized and treated as such. In so doing, however, it masks the socio-political context in which suffering arises, and in particular, the lack of adequate humanitarian assistance. And this brings me quickly to the second point of my talk today, which is asking, well, what does this mean for people's attitudes toward mental health and psychosocial support interventions in this setting? Well, in Palabek, most people were exposed for the first time to mental health interventions that were largely absent in rural and war-torn areas of South Sudan that they had fled. And they were, however, quickly alienated from these interventions and from the staff, and often developed quite a hostile attitude against them. Over the 13th month I conducted fieldwork, for example, despite raising tensions with the host communities and additional cuts in the humanitarian assistance they received, the numbers of people queuing in the mental health clinic dropped to close to a third of what they had been the year before. And this is largely due to the fact that refugees felt their voices were being actively ignored by mental health staff, who, despite certainly genuine effort, was perceived as active disengaging from the issues that refugees raised, and which most often involve socioeconomic needs. The two quotes that I put on the screen, I think, can be helpful in understanding this. A South Sudanese man who was diagnosed with depression explained why he was going to discontinue treatment and not going back to the mental health clinic, saying, "I keep on telling them about my problems, but these doctors, they don't want to help me. They just want to add medication." A refugee leader explained, "These people, they come here and they tell us not to think, to forget about the past. But how can you tell us to forget when you're not giving us anything to support ourselves? We have no work, the food is little, you are just fooling us." To conclude, what the case of Palabek refugee settlement, I think, clearly shows is that first, there is a need for mental health interventions to be fundamentally rethought in their design and implementation, and for their priority to be they're being built entirely around needs directly identified by the community. And secondly, what I would like to highlight here is that in settings like Palabek and in similar politically loaded and resource poor context, the move beyond the treatment gap and towards addressing the socio-economic roots of distress is a social justice issue, and it is a political choice. Avoiding doing this is a political choice as well, and because it results in framing them in solely psychological or psychiatric issues, which masks political roots of people distress. And this is something that the humanitarian system should be held accountable for. And I would like to leave you with this picture that I took at World Mental Health Day in Palabek, which carries the somewhat ironic slogan, "Think positive, save a life." Thank you. And I'm going to hand over to Pooja, I think.
Hi everyone. Can you hear me? And can you see my screen? Excellent. So hello again. My name is Pooja, and I work in Project Burans, which is located in the North Indian state of Uttarakhand. So we are at the foothills of the Himalayas. To give a little bit of background about what's happening here, first of all, the context is so similar to what both Constanza and everyone else was talking about. And we are, again, situated in a low resource community. And the terrain itself is a major challenge because we are in a hilly area, and the only major city, Dehradun, which is where we are located primarily, is the valley where all the services are concentrated. So keeping this in mind, we are looking at a population of more than 10 million now, with 40% living below the poverty line, and with 7 government psychiatrists now. It was 2 3 years ago. And we have 1 public psychiatric hospital with 50 beds and limited, or in fact, no other community-based care options apart from Project Burans running in the state. So this involves basically, access to care basically involves hours of travel down the hill, throwing up on the way and missing a day or two of income to get to a hospital, where the doctor sees you for less than 2 minutes and sends you off, saying that you need to come back in 2 weeks to get another set of medication. So the population that actually goes back to the hospital is more or less minimal. And there begins the first problem. The population, like Gina and Kosti were already talking about, they don't have faith in the services because they're like, the doctor barely listened to what I had to say. The doctor had no idea what I was talking about. He was all about looking at my face and writing a prescription of medicines, most of which I have to get from outside the hospital, which I cannot afford. And I cannot get more than 15 days worth of the free medication. So it's free medication, but it's not really free. The cost of actually accessing it just pushes the prices really high. And that starts the major issue from the beginning itself. So then, from the beginning, our approach in Burans has been to not push for people to access biomedical care. It has been to provide a community-based support system which addresses the social issues surrounding mental health, and at the same time advocating for reform of the systems that are already in place. And about 3 years ago, in 2017, this whole idea started in 2016, actually, one of our community workers who works with our clients, people with psychosocial disability in the community, thought of something different, thought of something unusual when working with one of her clients. She realized the problem that this person is facing is not whether or not they can access medication or whether or not they are taking medicines on time. The problem was addressing the social issues. So what she tried to do was understand what was important for this client, and actually ended up drawing a little chart with, the picture of a toothbrush, a picture of, a religious text, saying that this will be your schedule for the day. This is what you will follow. So that was where the idea of coming up with a co-produced recovery tool came up. And we wanted to know what this tool would contain that would be most relevant for the population we are working with. So going back to the issue where the clients are like, we don't feel like we are listened, like we are heard. The doctor is not listening to what we're trying to say. And so we don't feel like our problem is being addressed. We came up with this whole idea that let's ask the beneficiaries directly as to what they feel is most important aspects of recovery. And we also wanted to know how recovery, social recovery specifically, takes place in the area we're working in, and what approaches we can actually support to enable or to sort of help PPSD chart their own recovery journeys. And therefore, we started working with an experts by experience group, which had people with psychosocial disability, some caregivers, and we just worked with them. And one of the key things that came out of this was, again, the socioeconomic status of each of the households that we're working with. I still remember one of the EB group members broke down in the middle of the meeting and just asked, I don't know where my next meal is coming from. My husband beats me up every day. I do not know what you refer to when you talk about mental health, because the problems I'm facing are so relevant and so real that I don't know how to think about mental health. So there began this whole journey where we decided that we'll have all of these, or at least a lot of these social aspects as part of the tool available for each of the individuals to choose from. And therefore helping them chart their own journey to recovery. So if you see in this slide, you can see that this is the process with which we came up with contributing to the household. So it was not just about the burden of monetary contribution, which again lay mostly on the male breadwinner of the family, but also the contribution that enables someone to go and work outside, contributing to other aspects of the family, like, keeping the house clean, taking children to school, or something like that. So we came up with the participatory action research process. We followed that to actually come up with this Swasthya Labh Sadhan, which is we call it SLS, because Swasthya Labh Sadhan is a mouthful. So that's the name of the co-produced recovery tool that we're using. And again, we had to make sure that it was a pictorial tool, considering that a majority of the population we're working with, many haven't gone to school, and we needed that tool to be as accessible to the population as possible. And of the population of the 31 households that participated, most were people with common mental disorders. You can see a quick profile there. And we had a few people with severe mental disorders participate, but again, these were people who were functional to an extent, were already on medication and working on these issues. So we had the different pictures that were depicting different themes and activities linked to these themes. But what was key in this whole process was understanding what was contextually relevant in that particular area we're working in. So hence the role of the Experts by Experience group in designing the tool, and then giving the person with psychosocial disability the right to choose what they felt was their biggest need to work on. And I think that sort of was really key in this journey, because there were people who we were working with who had multiple issues. So there was a person we were working with who had both epilepsy and depression. But her epilepsy was controlled by the medication she was taking, but her depression was linked to the stigma and the the gender roles that she was facing, and the society putting sort of these restrictions on her based on her status as a person with epilepsy. So it was really interesting to see her journey working through these issues using the tools. And on top of that, it was also useful to see that parallelly, so we have more than 3,000 people enrolled till date on the project, but only 31 of these people were invited to participate in this recovery tool use. And parallelly, with the lens of what's happening in this tool, we are also noticing that the other work we're doing addressing the social determinants is taking its own trajectory, so to speak. So we, at that time, had a livelihood project also running parallel to our mental health support work. And one of the things we did was to identify people who could benefit from a mini business model sort of thing. So what we were looking at was a small poultry farm, for people to actually take care of the chicken and sort of feed and handle the daily needs of a chicken. So we worked with a lady who was about in her 30s, and she was diagnosed with a common mental disorder for a long time, and she was living with her mother. So when she got these chicks, the poultry, it was really wonderful to see how much her view of her own disease changed, and how much the view of her mother, thinking of her as someone who cannot handle things, changed. So the mother was actually saying that, I cannot believe this is my daughter taking care of the chicks and actually handling something. I never thought I would see her managing so much. And now it's also a source of income for the family, because the mother was going into depression, thinking, how will I handle the family? The socioeconomic status of the family was pretty bad. And therefore, addressing the livelihood issue helped the person with depression and the caregiver, who was also going into depression, to sort of come out of the situation and see a change in their own status. So that was also something interesting that was happening parallel to this. And with the tool, some of the things that we were addressing were some gender norms, so to speak. So we had things like, so we did not say that earning or contributing to the income has to be a male role, or that playing and going out and playing with friends has to be a male dominated activity. So we gave freedom to everyone to choose what they wanted. And it was also interesting to see how women who were in their 40s, who have never left their little town, traveled all the way to Dehradun, which is an hour's drive, and attended a sports tournament, And she was in tears because she's like, this is the first time I have left, the 10 feet radius of my house. And she was in tears because that was such a small thing, a small component of the tool, but she sort of charted that own journey for her. And just getting out of that zone was so important for her. And it's these scheduling things that we've got in the tool are sort of indicators that these are the areas that people need to work on, that they themselves feel they need to work on, and therefore was really useful. And the community health worker relationship with the person with psychosocial disability was very important in this tool, because it's what we call a therapeutic alliance. That is what was not being provided by the doctor in the hospital who was consulting for less than 2 minutes. And the value of that was highlighted with the use of this tool. And it was also about looking at how contextually valid the tool is, and how accessible this is. And working with the experts by experience group was really crucial in making sure that the tool is relevant and real for everyone using the tool. And I think that's what has led to the tool being successful among the 31 participants who used it. I'm not saying all of them benefited, but the averages actually show that the self-reporting questionnaire 20 form, which we used, shows there has been decreased depression and anxiety among the users of this tool. And qualitatively speaking, we have seen a vast difference in the conversations, especially around people who have been facing depression and anxiety and have not had positive results going to the doctor particularly. I think that's all I've got to say. I hope I've addressed everything. And I should be handing over to Rochelle. Am I right?
Thanks so much, Pooja. Yeah, I think we've got Rochelle and Alex to kind of draw together some of the strands of the different talks and offer some of their reflections on key themes and where do we go from here.
Thanks. Thanks everyone for amazing presentations. I'll start and then I'll hand over to Alex. I think one of the things that's so inspiring and special for me is that 10 years ago, I started my PhD in global mental health when it wasn't really a thing yet. The 2007 Lancet special issue had just come out, and I tried to do something that confused a lot of people. And it was, I wanted to ask people what they thought their problem was. How would you define your problem that we're trying to define as depression or anxiety? In a part of the world where theoretically good policy existed, so my work was done in South Africa at the time, and in sort of a very rural part of the country where there were a lot of sort of intersecting challenges in sort of women's lives. What Patricia Hill Collins would call sort of like matrices of oppression. And when I sort of presented this work, I remember one of the things that I was asked in my PhD examination by the brilliant Leslie Swartz was, some people do PhDs on HIV, women, or depression, or how did you decide to do a PhD about all of those things at once? And the answer was, because that's just what their life is. It is all of those things at once. Your people's lives are about poverty, oppression, gender marginalization, violence, and their emotional response to that, and their emotional and life world response to that. And I think for me, one of the big difficulties in the sort of treatment gap paradigm or the global mental health paradigm as a whole has been attempts to separate those things into actionable areas of engagement. So we will work to define prevalence under these categories, and then we will work to understand discrete social determinants as they might impact on people's lives, and we separate them. And in that separation, we get further and further away from the compounded impacts of these dynamics and the way in which a wider political economy and a socio-political economy ultimately comes to bear on people's lives. And I think that that's the reason why my work in South Africa, my work in Colombia, my work in the UK with marginalized groups from Black African and Black Caribbean populations all tell a very similar story, because the political and socio-economic forces acting on those lives are basically very much the same. Maybe have slightly different lineages, but they're the same. And so what I think this collection of talks really sort of pushes us to get towards is to acknowledge that we have been in a space for a long time that, while trying to do good, has contributed to erasures, really significant and potentially harmful erasures of people's stories and what people bring to the table in trying to advocate for themselves in search of solutions to the problems that drive their distress as they see it. And in trying to make sense of how we respond to it, we use the paradigms that we have to hand. A global mental health paradigm, as many have said, was anchored very much to psychiatry, to psychology, to thinking about psychology and socio-relationships. So even when we talked about the social, we weren't very good at thinking about the socio-structural. And so that's one, this sort of the way in which we've done these types of erasures. And also ultimately how I think we're trying to get to a place where we start asking different questions. I think previously we've been asking the wrong kinds of questions because we weren't, because the questions weren't open enough. The questions were predefined by the paradigms within which we were working. And so I sort of think in the last sort of few years and sort of really inspiring work by sort of early career scholars who I wish you guys were doing PhDs at the same time as me a billion years ago. I would have felt a lot less lonely. But ultimately showing us that if you change the question that you're asking, if you ask your questions in a different way that are open, you will gather these multiplicities of discourses that will lead you down pathways to reimagine services. And that doesn't mean that we are leaving one for the other. It doesn't mean that we stop investing in mental health services, because as Georgina said in her, if it highlights in her work, for some people they work. And when they do work, they should be available. I think ultimately it becomes a matter of acknowledging that the people that come into those services, as Pooja sort of highlights in her work in India, that people can define what their problem is for themselves. And when you give them the space to do that, you open up opportunities to promote well-being on a much broader scale that will have impacts across the sort of constellation of people's challenges. And so I guess my hope for the future of global mental health is that we try to focus on the development and and sort of the empowerment of methodologies that allow us to leave space, and methodologies that are transformative in doing our work, particularly in a research space, because that avoids us from continuing this erasure of complexity in the name of simplicity that doesn't really make sense in the world that we actually live in every day. So yeah, I could say lots more, but I won't, and I will hand over to Alex, and then hopefully we can touch on a lot of the different scribbles. There's the scribbles in our wider discussion. So thanks very much for having me, guys, and thanks for your brilliant presentations. They were so great.
Thank you, Rochelle. That was great. And thank you, everyone, for giving me the opportunity to participate in this. Where do I begin? You know, the concept of the treatment gap very basically grows out of the global burden of disease study. which says there's tremendous need and we have to address it. But the global burden of disease is based on population level data, and service use doesn't follow that. I think we need to start looking at other ways of determining who's in need. Perhaps severity versus prevalence, which means that we focus on psychosis, epilepsy, and that relatively small percentage of people with depression who need clinical care. Because even if one addresses all the social inequalities in mental health, there still will be people in need of psychiatric or psychological care. There isn't a dichotomy here. Both need to be done. So what types of interventions do we need? Certainly we need social interventions. Probably the most dramatic for me is discussions around suicide. One of the things that I disliked most about the 2007 Lancet series, and Ricardo Araya and I got into some trouble about this, was the idea that you could measure the success of a mental health system by following national suicide rates, which is ridiculous. Mental health care has little influence on suicide rates, which follow economic and political crises over time. So what sort of interventions do we need? Certainly the idea of locally important outcomes is very, very compelling. What do people want in specific locales? I would refer you back to some work that's 20 years old now by Paul Bolton about doing pile sorts among communities and asking adults, what are the most important tasks of an adult in this community? And seeing whether people are meeting those tasks. I think it's a wonderful concept that hasn't been explored enough. But also, let me just draw on some experience that I've had in Goa, India, in a couple of trials that I was involved in. In both trials, it became very, very obvious very early on that what was needed as part of the psychological or psychiatric interventions was referring people to community services or helping them access community services. And also, I don't want to underestimate the tremendous importance of just having somebody to talk to. This was especially true in a trial with older adults in Goa. And most of them kept talking about, when we did follow-up, how wonderful it was to have visits from nice young people. Just sort of social connection, helping people to doctor care. And going back to the idea of severity versus prevalence, I don't mean to say that we should only be treating psychosis or epilepsy or clinically significant depression. But I was listening to a presentation yesterday or the day before by the founders of Partners in Health, the sort of parent program that oversaw the program in Chiapas. And their basic orientation is everyone, everywhere deserves the best care possible. And I think we have to keep that in mind, but we also have to keep in mind, what is the best care? What do people want and what do people need? And I'll just end by saying, actually, a few years ago, I met a bunch of graduates of the MSc in Global Mental Health at a conference in Prague, which was a conference of young psychiatrists. And I made the terrible mistake of titling my talk, Global Mental Health is Not Psychiatry. It was not received well, but I wouldn't back down from it. Global mental health is not psychiatry, and the field in a way suffers from the fact that the field was founded mainly by psychiatrists. And if we were to become a true public health field, we need to look at different types of interventions and different types of engagement with the mental health of populations. So I'll leave it there. Thank you.
Brilliant. Thank you so much for that summing up, Alex and Rochelle. That was really, really helpful. Does anyone have questions they want to ask? There's quite a few comments in the chat, but I don't know if anyone wants to actually ask them out loud, have some discussion. Or comments, reflections, they don't have to be questions.
Hi, Tessa, I would be happy to make a comment.
Hi, Nora.
Nora here. Hello. It's very nice to see everyone and so many familiar faces. And it's always lovely to talk in this group because I feel we all have very similar opinions. So in a way, I don't know if we're living in our own bubble, but to at least raise something that I think is a little bit controversial. Maybe you're taking things one step further, that if, from what I've heard here in the talks and what we keep seeing, social factors are the main driver of mental health needs that people are informing. So if we're seeing this repeatedly, if Pooja was talking about having social recovery as a kind of separate concept, but I wonder if it's not just social recovery, it's the whole of mental health recovery should maybe consider this social aspect as the key goal and what mental health services should be addressing. This is a little tricky because, of course, mental health professionals are psychologists and psychiatrists typically, so you wouldn't have a lawyer and a human rights advocate at a mental health service. But I wonder if having social recovery as a separate concept from recovery in mental health ends up acting in detriment of really understanding that the problems that people are informing are social.
I could maybe say something if that's okay. I'd like to really thank everybody for just such brilliant presentations. It's been really delightful to listen to these in the gloomy, cold weather here in the UK. It's getting darker here. I don't know where other people are. But as I was listening, it really made me think, you know, what you've been talking about is really this upstream prevention of in this case, mental health problems. In other fields where I've been working and been hearing this same kind of thinking has been upstream prevention of HIV prevention, upstream prevention of violence interventions. And there is something I think about quite a lot about is what would poverty reduction interventions look like in different settings. And I often get overwhelmed thinking, well, if Oxfam and all these other kind of large aid agencies who've been thinking about this for a long time haven't figured it out, then how do we figure it out? But I think that one of the kind of positives is if we can figure it out, and I think potentially it needs to go beyond cash transfers, but something that's more meaningful for people, then you have lots of big wins there as well. So, you know, if you can do poverty reduction or make that work, then it will impact positively in several domains of people's lives, mental health being one of them, but, you know, violence reduction, HIV, potentially alcohol reduction and these other domains, and keeping girls in school as well. So that there are some big wins out there if you can do that, if you can design something. I feel that it would be really it would be a really positive thing if there were some sort of successful upstream interventions like that, which tackled poverty.
I just want to jump in because I think both those two comments are really important, and they sort of relate to each other. And a bit of the sort of work that I've been doing over the last couple of years is trying to find a way to one, broaden the way that we think about responsibility in sort of the mental health space. In essence, that we don't need to have a separate model of social recovery, that actually social recovery and thinking about the socio-structural is a part of anybody's recovery. As soon as you start spreading them apart into different paradigms, you end up with this model where mental health is everybody's responsibility and nobody's responsibility at the same time. And one of the things that sort of came up from my PhD, which I remember, like I will never forget, is a social worker who was on their sort of multidisciplinary team who said, as soon as I give somebody a diagnosis, it's impossible for them to get anything, because if they take that diagnosis or that medical card to the social development office, nobody's going to see them because of stigma about mental health. So we try to separate them to think we can just refer people through systems to get social recovery. But I don't think that that's what needs to happen. We need to redefine how psychiatrists, psychologists, doctors, allied health professionals see their role. And as part of that means coming up with different types of interventions that can become embedded in the places where people work and do health-related sort of support. And so looking at sort of blended models where you know, income generation projects happen alongside or within sort of group therapy paradigms. And there are increasing examples of those that have seen some success in different parts of the global South. One of the ones that I have recently done a pilot evaluation of is collective narrative therapy, which is sort of a group therapy that sort of works embedded within storytelling to sort of reimagine and redefine the self positively, as opposed to through a lens of trauma, a lens of survivorhood. And that was embedded and anchored to training on how to do sort of like savings banks, like sort of running sort of like community banks and local banks, sort of penny savings, to help people within these sort of groups where they've built solidarity and positive senses of self, and increase sort of those individual dimensions of well-being that enable them to collectively participate on an action or activity, start to sort of raise income in sort of very small local ways that has meaning, that they can use to then have meaningful impacts on sort of separate projects of action in relation to their lives. And one of the big goals is to have something like that not happen in an NGO, but to be embedded within a health system, because why not? Because why not? I actually can't think of a reason why not anymore. So I'm just gonna continue pushing it until we find a way to sort of make it happen, because those are the types of spaces where interventions where we stop separating people and we acknowledge that both of these things are happening at the same time. So yeah, there are examples of those types of interventions out there, I think, Tara, and we just sort of need to sort of continue to push and expand their implementation.
I think I was also thinking about upstream prevention, so not once someone's become poorly, but to stop that happening in the first place. And I think you were talking about recovery, and I think they're both important as well. But that was where my thinking had originally been. Anyway, I won't take up any more airspace.
You mean sort of large scale sort of interventions, population level interventions to prevent
structural interventions, yeah.
I mean, there was...
Yeah, go on, Tessa, sorry.
I was just going to say, I mean, we do know a lot about kind of policy decisions that can make an impact on poverty, and that can make an impact on mental health. So there's, Martin McKee's worked on evaluations of increasing the living wage, the minimum wage, for example. You can really clearly document the impact on people's living standards and the impact on mental health. So I think part of it is, is not about relying on aid agencies necessarily, but it's about kind of lobbying for policy, either at the local level or at the national level or an international level, that is promoting of the factors that we know make a difference for mental health. And obviously, these are not the sort of quick win things that you can just, do a randomized control trial, find it's effective, and then try and get people to scale up. Although obviously that's where things fall down a lot. But they are the things where you could have a massive difference. And I wonder if we're talking about our role in global mental health as being part of that sort of political advocacy enough. I think Ursula has a question.
Thanks, Tessa. Thank you for just an amazing session. I really enjoyed all the presentations. It's just, and I totally agree with what you're saying as well about these policy level interventions. But I also think, kind of bit to follow up from Rochelle's point, is that actually a lot of these public health type approaches are being done, but they're being done under the radar. So I think, because I'm very interested in how people kind of do mental health work, and the nurses that I know from where I work in Ghana, although they're mental health nurses, I mean, a lot of their labour is around addressing precisely the kind of social causes of mental health, but it's kind of an invisible work. Because it's not, it's not measurable in the same way, and it's often done under their own budgets, in their own time. And so I think, reimagining the ways, I think there's a lot we can learn from those kind of settings, about reimagining the ways that services are organised, not in these very compartmentalised ways. I mean, Ghana, for example, doesn't really have many social workers working in mental health. So, but that kind of work is being done in these kind of in-between spaces. And I think the policy level interventions, like you said, in the ways that I think public health has done quite successfully, smoking ban being a very obvious example, these have mental health effects. And I just had one other point in relation to psychosis, I don't think these arguments are not separable between common mental disorders and psychosis. So even you can give people chlorpromazine, but if you don't also address the social causes, then that's going to have a very limited effect. Thank you. Thanks.
Ursula, I'm glad you brought up the question of psychosis, because you and I have been interested in this for a very long time. However, I think you're right that social programs are incredibly important for people with psychosis, but I do feel that global mental health as a field is neglecting relatively neglecting persons with psychosis, and ignoring what's going on in hospitals. Well, that's not entirely true. Sumitra Pathare is doing work in hospitals. This is a social question, these hospitals, but where is the concern? Sometimes I really fear that one of the great problems in the so-called treatment gap is it's been entirely on common mental disorders, almost. I just don't want psychosis neglected or forgotten about in this conversation.
I guess part of the reason we were quite careful to make sure that we weren't generalizing from research on common mental disorders to disorders like psychosis was certainly in my research, people drew a very clear distinction between sort of everyday stress and tension that is seen as normal, is seen as linked with people's circumstances, and mental illness. So they didn't see common mental disorders as mental illness, whereas psychosis and
you're
sort of
absolutely
intellectual
right.
disability
Right.
were seen as mental illness, that people often did see the need for some kind of health interventions or some sort of specialist support. So it's, Ursula is obviously right to highlight the fact that the relevance of social factors also for severe mental illness. But I think the way that people think about it and the way that people respond to it is certainly, you know, from the qualitative work I was involved in India was quite different.
Yeah.
I sorry to I think in a way, because we just had a very interesting lunchtime meeting thinking about categories, and I think that's part of the issue in a way, is because it gets categorized as madness, right? So then it's like Rochelle was saying, you know, you come in with your card with mental illness written and then it cuts it off, and I think that's the problem. Then we see it as, I mean, and it's, you know, that in Ghana, you know, people see madness as completely other, so it kind of blinds them to the social issues that might be exacerbating those issues. So it just all becomes thrown into the madness box. It's madness, so we don't have to mind them, you know, and there's nothing you can do, they're mad, give them the medication. And so I think that's my worry. And of course we know that lots of people who are mad or have psychosis also have depression or other types of you know, because it's not an easy thing in this world to be psychotic. So yeah.
We have 3 minutes left. Does anybody have a final question, comment, suggestion for how we move forwards to end on?
Just very quickly, Sumit Jain, who I hope is still on the call, will be able to talk about this far better than I, but I think we really need a social work model rather than a psychiatric or psychological model, helping people to figure out their needs, figure out how to meet them, helping them. And your question, Tessa, on the chat, I was not referring to community mental health services. I was thinking more broadly in a social work frame.
Not to put you on the spot, Sumit, but do you want to add anything to that?
Yeah, thanks very much, and thanks to everyone for the great presentations. I really felt inspired by the talks, and it's just great to hear these things coming out in a sort of form. Social work. I mean, social approaches, yes. Social work approaches, yes. Social workers, yes, maybe. But I think, you know, there's a whole issue about who does this work and who's best placed to do some of this work. And I think you know, I think we have lots of examples of really, and you know, in the context of Pooja was talking about, of really good community workers doing excellent social work, which my colleagues, you know, in my profession would say, some might say, well, this is not social work, but I would say it is social work. So that's one thought I had, just in response to what Alex was saying. I think we need to take some of these approaches, yes, and think about social capital, think about recovery, think about connections and support and care and support. But but thanks very much. It's really left me a lot of food for thought, and also a lot of, I guess, a sense of hope that there is, that I'm still stuck in terms of your question, Tessa, the one you just posed a couple minutes ago. Where do we go forward with this? I suppose maybe Sumitra Patari's point about a care gap, which he's written about, is also, I mean, I was thinking about this yesterday about the gap thing, and I'm always telling my students this gap and that gap and that gap, and I just wondered, is there a way we can away from gaps, because it just feels very, very negative, sort of, it feels like we're almost with a lack. And actually maybe this, and obviously Rochelle has talked about competencies in her work, and I think that's also a really great approach of this idea of community competencies. But I'll stop. Thanks.
Thank you so much. We've come to the end. We're bang on time. Quite proud of us there. I just want to say thank you so much to everyone who shared their work. Thank you so much to everyone who's joined. There's been some really useful things shared in the chat box that I'm going to take away and read. And thank you for everyone for the great discussions. Hopefully we can keep some of these discussions going through both centres going forward. So thank you.
Thanks,
Thank you so much, everyone.
And everyone.
Thank you, everyone.
Bringing us all together.
Bye-bye.
Thank you. Bye.
Bye.
Bye.